Alright, we're on to our next section on the skeletal system, and we're going to take a look next at what happens when a bone breaks, the process of repairing bone fractures and getting the bone back to being hopefully as good as new. So the next step here is to see what happens when the bone first breaks. And when a bone initially breaks, there is going to be both bleeding and clotting around the site of the injury. That's kind of a given. Um, Along with that bleeding, there's going to be sort of an invasion or an incursion of fibroblasts. Remember, these are those cells involved with producing connective tissue that are going to start secreting collagen and get to the production of what's called a callus. So down here we see broken bone, we see a blood clot or a hematoma, and there's the beginnings of what's called a callus here. And the callus, initially, what it's going to do is to help protect the maybe perhaps jagged ends of that bone from doing further damage either to each other or to the surrounding tissue, so we want to prevent that as much as possible. The callus also helps to link the bone. In a way, it's kind of like a built-in setting mechanism to help these separate ends of the bone kind of link together. There's cartilage here as well. Remember, cartilage is part of the bone to a degree early on, and later on as well. It kind of maintains itself with the bone. From there, once the cartilage is there, we see osteoblasts. Remember, these are the bone cell precursors that are going to start turning cartilage back into bone again, just like we saw back with the developing skeletal system. We saw that previously. It's kind of the same thing here, right? So we have bone cells. They're going to start replacing cartilage with bone. Eventually, what initially began as a collagen-based and cartilage-based callus is going to become a bony callus, and then eventually that bony callus becomes a healed fracture. And it's never quite as good as new, but all things considered, it does do a pretty good job of repairing what was initially a very, very severe injury. You think about what it looked like back here versus what it looks like over here. It's really remarkable what the healing process can do when it comes to bone. Now, with bone remodeling, this isn't necessarily where you have a break of some sort, but you do have a modification of the walls of the bone itself in response to stress. And so, as we know, bone is a very dynamic and changeable tissue. I mentioned previously, I think in the last section, where if you have a weightlifter, for example, lifting heavy weights, that's going to cause stress on the bone. So if you imagine just a bone by itself, imagine this is the shaft of your femur. So we have somebody lifting weights. We have a force pushing down on the bone. We have the reaction force or the strength of the bone pushing up. What that's going to do when these two forces meet in the middle is it's going to cause a bit of a flexation of the bone here. And the bone doesn't really like that so much. So what's going to happen is that these cells, again, these osteocytes, are going to start adding more and more thickness or volume to the walls of the bone to make it sturdier, to make it so it doesn't flex as much. And so the walls of the bone get thicker. And as the walls of the bone get thicker, and since they're stronger, if you have the same force pushing down and the same force pushing up, now the bone doesn't flex as much. The danger here is if this was really, really, really super heavy weight, the bone could flex so much that it would cause a breakage of the bone or a fracture of the bone. So to prevent that flexing, what the body does is to kind of acclimate itself. It adds more and more calcium phosphate to the walls of the shaft of the bone, which gives it greater thickness, greater strength, and therefore less inclination to flex. So we can have not only a change in thickness, we can see a change in surface features over time. We even see this now from time to time in osteoporosis patients where of course, osteoporosis is a loss of bone mass over time for various reasons, typically postmenopausal. One of the treatments, more modern treatments, I suppose, for osteoporosis would be to actually prescribe a very limited, very supervised type of weightlifting to patients who are suffering from osteoporosis. So it's kind of an image of grandma in the gym, doing squats. Not really that kind of weightlifting, but certainly some to encourage the bone to add density back where density was lost previously. And so this, again, is one way to do that. We saw back in our chapter on the endocrine system the various hormones involved with either adding thickness to or removing calcium from the bone. Calcitonin is the one that's going to cause blood calcium levels to go down. And of course, when blood calcium levels go down, one of the places where that calcium is stored is as calcium phosphate in the walls of the bones. So calcitonin, while decreasing blood calcium, actually increases calcium storage in the bones and can make them, in fact, stronger in a way. By stimulating osteoblasts, they're going to take calcium out of the blood and use it to produce more bone. Osteoclasts, on the other hand, remember osteoclasts are the ones that tend to break down bone, and so with calcitonin, we see this twofold effect. We have a stimulation of the bone building cells and an inhibition of the bone breaking down cells. And so the overall effect is that bone is going to take on mass. Parathyroid hormone, which is the antagonist to calcitonin, has the opposite effect. So parathyroid hormone, or PTH, is going to help increase blood calcium levels for the exact opposite reasons we saw with calcitonin. So now we're going to stimulate the osteoclasts. They're going to break down bone. They're going to release calcium into the blood, and we're going to inhibit osteoblasts. So we're going to inhibit the bone building process. We're going to encourage the breakdown of bone, and both of those things together are going to help increase blood calcium. The effect of estrogen on bone, of course this is primarily in females, is going to be to increase absorption of calcium from the digestive tract. And so as long as you have somewhat high doses, relatively high doses of estrogen in the blood, there's going to be a decent amount of calcium uptake from the intestines when you consume calcium in your diet. And of course that's going to help encourage bone formation. Now, one of the things that occurs is that once menopause has kind of progressed and passed, of course estrogen levels are going to go down as a result of that process. And with a decrease in estrogen levels comes a decrease in bone formation and a decrease in the thickening of bone, a decrease in the absorption of calcium from the diet, and those things can of course lead to osteoporosis, which is a decrease in bone mass over time to the point where bones become very fragile, very breakable, relatively thin-walled, and in many cases a very debilitating kind of condition. So now we're going to focus on the different parts of the skeleton, such as they are. We're going to see the axial skeleton first. And so the axial skeleton primarily consists of the cranium, the vertebral column, all the vertebrae, the sternum, which is the breastbone. See the sternum right here kind of in the front, really thick, heavy bone here in the front, and then the rib cage on both sides. Okay, so that's the axial skeleton. Primarily the axial skeleton is involved with protection. So you're protecting the brain, you're protecting the spinal cord, you're protecting the lungs and various internal organs with the ribs. Very much a protective sort of a function. The skull itself is made up of multiple bones. There is the cranium, which is kind of the main back, larger part of the skull, as well as the facial bones up here, as we see with the lacrimals and nasals and zygomatics, maxilla, mandible, and so forth. These are all the facial bones up here, the orbital bone as well. So the cranial bones back here, so frontal, parietal, temporal, occipital, those are all involved in protection of the brain. There's also, as it pertains up here, the housing of the hearing structures, the auditory structures, both outside and inside, very small bones inside as well for transducing sound. There's also attachment points here along the way for muscles. So when it comes time to move the head up and down, back and forth, the neck muscles have to have something to attach to, and in many cases they're going to attach to various points on the skull. Facial bones there's more of them. They're smaller overall, so now we can take a look at the facial bones. In this picture we see the nasal, the zygomatics here on sort of the part of the cheek, maxilla, which is what you consider, I suppose, the upper jaw, mandible is the lower jaw. That's kind of the front view of the facial bones. So we see sensory structures here. We've got the nose, we've got the tongue, we've got the eyes. We've talked about the ears before as well. And again, we have attachment sites for muscles. It doesn't do you any good to have muscles unless they have a point at which they can attach to cause that particular thing to move. Think about all the very tiny, fine muscles in your face that are responsible for not only speech, moving your mouth, moving your tongue, and so on, ingestion of food, chewing of food, but also facial expressions. There's a lot of muscles associated in the facial region that are involved in helping to produce expressions, as well as the various other functions I talked about as well. Shortly after birth, after an infant is born, we see an incomplete hardening of the skull in particular. So in between the plates of the skull, there are membranous areas that connect the skull plates together called the fontanelles. And the fontanelles are there early on initially to help assist with childbirth. So what you can imagine here is if an infant were born, even a relatively average sized child, 7.5, 8 pounds or so, the head is still relatively large, and giving birth to a child with a head that large would be extremely difficult for both mom and infant. So rather than having a completely solid, immovable, immobile skull, there are these areas of connective tissue in between the bones, so that during the labor process, during childbirth, as the baby is being born, these bones have a little bit of flex to them because they're not directly and firmly attached to other bones, they're attached to connective tissue. And so as baby is emerging from the birth canal, there is a bit of flexibility here. The bones can sort of move back and forth past each other and make it easier for both parties involved, both mom and the infant. So if you've ever held a baby, an infant, no doubt mom or whoever told you to be careful because there are soft spots in the head and so on, and that is true. Those are usually replaced by about the age of 2. By that point, the connective tissue has been replaced by bone, and it's a much more supportive and much more protective kind of a structure. In terms of the vertebral column, we see a range of vertebrae here going from the 7 cervical vertebrae, these would be like in your neck, to the thoracic vertebrae, which kind of meet up with the ribs in the front. So these are going to be attached, some of them at least, to the ribs, thoracic vertebrae. Lumbar vertebrae on your lower back. The sacrum are five vertebrae that are fused together in one structure here. So this is the sacrum. And then eventually down here, the coccyx is 4 vertebrae that are fused together. And this, in many regards, is the remains of what, embryonically at least, was a tailbone in us. We all would have had a tail. This is what remains. This is the bone, the tailbone that remains after most of the tail has been reabsorbed during development. So we see a huge range of vertebrae here. Even though some of them are fused together, others are much more individually articulated. They move back and forth past these discs. There's cushioning between them, and there's a lot of motility here. This is the primary example of segmentation in a vertebrate body, would be in the spinal column. The discs that sit in between these vertebrae are prone to deterioration. They tend to break down as you age. They're also very prone to injury, so if you lift things improperly, if you slip or rupture a disc, it can be extremely painful, as we lose the sort of facilitator of movement between the vertebrae. If there's damage there, it becomes very painful to move as a result. Scoliosis is another condition which usually expresses itself early on in life with an overcurvature of the spine. So rather than having this curvature here, which is relatively normal, if this is more exaggerated, especially down in this region, that can cause a lot of complications and difficulties, pain also when someone is growing as a child. As far as the rib cage, we're looking at about 12 pairs of ribs that attach at the thoracic vertebrae and then meet in the front here at the sternum. There is cartilage that actually finishes off the connection between the rib and the sternum. This cartilage can be extremely painful if torn. Speaking from first-hand experience, I actually have done that, and it is not a pleasant sensation. This cartilage, it's flexible. It allows expansion and contraction of the ribs as respiration occurs. But if it's ever damaged, simply breathing causes a lot of pain as a result. The floating ribs are those that are down here toward the posterior. There's here as well as here. These ribs are actually not attached directly to the sternum. They're attached to the thoracic vertebrae, and then the reason why they're called floating ribs is there's no attachment point out here. So 2 floating ribs on either side. And again, those, because they're not supported in the front, are those that are perhaps most vulnerable to damage or to breakage if some sort of traumatic injury might occur. Now, the appendicular skeleton is made up of everything else. So when you think about appendages, what are appendages? They are arms and legs. So the appendicular skeleton is going to consist of the arms and legs. So for the arms, the point of articulation between the arms and the axial skeleton would be the pectoral girdle, otherwise known as the shoulder. So the biggest bones back here are, at least the scapula is a relatively large bone. This is what you would call the shoulder blade that's kind of in your back. We also have the clavicle here, which is a collarbone, often injured, frequently broken sort of a bone here, especially when it comes to falls. Typically when someone falls, what happens is if they try to catch themselves with their arms, the force of the fall, the shock of the fall is transferred up through the arms into the clavicle, which is relatively delicate, and it breaks. And that's probably not really a bad thing, because if it didn't break, if that force were transferred up through the collarbone and were to continue on, it would cause further injury further up into the axial skeleton, which is certainly something you don't want to have. The pelvic girdle is made up of the 2 pelvic bones that join in the front. It's what's called the pubic symphysis, which is where those bones connect together. So we see the 2 pelvic bones, left side here and right side here, and they're joining together right there in the middle. So there's a point of connection there that joins those together. From there we have the limbs, and so limbs are moved from everything from locomotion to feeding behavior and those sorts of things as well. We take a look. We're not going to look at a huge amount of detail for any of these bones, but in the leg, for example, we have the femur, which is the thigh bone, the tibia, which is the larger of the 2 leg bones, the fibula, which is the smaller of the 2 leg bones, the tarsals, which are in the ankle, the metatarsals, which is most of the foot, and the phalanges, which are the toes. Kind of a parallel situation in the arm. We have the humerus, which is kind of the equivalent to the femur. We have the radius, which is more or less kind of like the equivalent of the tibia, although these two bones are more similar in size than tibia and fibula are. Ulna is a little bit smaller. And then we have the carpals, which is the wrist, the metacarpals, which are the hand, and then the phalanges, which are the fingers. So down through here are the remains of the phalanges. All right, the last section we're going to look at is a section on joints. And this section is going to take a look at what happens when bones come together, where they meet in the middle. Okay, so the first thing we need to look at here is classification of the different types of joints. There are fibrous joints, there are cartilaginous joints, and the most common type are called synovial joints. So we'll take a look at all three types, but in particular we want to focus on the synovial joints. I'm just going to pause for a second here, and we'll pick up with the last section so it doesn't get to be too long.